Good afternoon, everyone, and welcome to Citywide Medical Grand Rounds today, Thursday, May 8th. We are at St. Joseph Healthcare Hamilton as the host site for today. Next slide, please. So I am Dr. Madeline Verhofsek. I'm the Chief of Medicine at St. Joe's and pleased to be co-hosting today. Next slide, please. So we'll start with a land acknowledgement. We acknowledge that St. Joseph's Healthcare Hamilton sits on the traditional territories of the Mississaugas and the Haudenosaunee nations and is within the lands protected by the Dish with One Spoon Wampum Agreement. This is a treaty between the Anishinaabe, Mississaugas, and the Haudenosaunee that bound them to share the territory and to protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. Next slide, please. And so for today's Citywide Medical Grand Rounds, it is my pleasure to welcome Dr. Tala Abu-Hijleh, who will be presenting on the topic of thyroid cancer for the internist. I'm also pleased to welcome Dr. Rima Shah, who is the head of service for endocrinology at St. Joseph Healthcare Hamilton and the medical lead for the diabetes program at St. Joseph Healthcare Hamilton. And I'll hand things over to Dr. Shah, who's going to tell us a bit more about our speaker.
Thank you, Dr. Verhofsek. So Dr. Tala Abu-Hijleh is our latest recruit here at St. Joseph's Healthcare Hamilton in endocrinology. She completed her internal medicine residency in Ottawa, followed by an endocrinology fellowship here at McMaster. She then completed a thyroidology and thyroid cancer fellowship at the University of Toronto before coming on here at McMaster as faculty. She also has a previous master's in health professions education. Her current practice consists of a mix of general endocrinology and thyroid cancer care, and I can speak for all of us at St. Joe's that we've really benefited from her expertise in the area of thyroid and thyroid cancer, and so her topic today I'm sure will be very relevant for all of us. So thank you, Tala.
Thank you, Rima, for that introduction, and thank you for the Grand Rounds Committee for inviting me to speak today. So I will get started. The thyroid cancer for the internist, my talk today is going to focus on a hypothetical thyroid cancer patient's journey. So we'll kind of start at the beginning and speak a little bit generally about thyroid cancer, and then we'll go through the process of the journey from diagnosis to treatment to give us an idea of what that looks like for our thyroid cancer patients. I don't have any conflicts of interest to declare for my talk today. And thyroid cancer, so the broad categories of thyroid cancer are differentiated thyroid cancer, which includes papillary, follicular, and oncocytic. About 80 to 90% of thyroid cancer is papillary thyroid cancer. So when I say thyroid cancer, that's what I'm referring to in this talk. Then we have poorly differentiated thyroid cancer, anaplastic thyroid cancer, and medullary thyroid cancer, which I won't be touching on today. So I just wanted to start off with the reputation that thyroid cancer has, which is the good cancer, which many of you may have heard. To touch on that, so from a patient's perspective, I don't think any cancer is considered good, so we should keep that in mind. And although the prognosis for thyroid cancer is very good overall, that doesn't mean that the thyroid cancer journey for the patient is an easy one. So it does still often involve surgery, radioactive iodine, surveillance, scans, personal anxiety about the process. And so we don't really want to use that term to undermine the patient's journey. And who treats thyroid cancer? So in different centers, it's very center dependent, but there's a lot of people involved in thyroid cancer. And it kind of has a nickname of an orphan cancer because it doesn't really have parents. Everyone kind of dabbles in it a little bit. So we have our ENT surgeons who are operating, medical oncology, endocrinologists, radiation oncologists, nuclear medicine, and to what degree they're involved varies at different centers. And that care can be a little bit disjointed for patients sometimes, and a little bit confusing and a little bit redundant. So that's a part of thyroid cancer care that we still have to work on. And then overall, it's a rapidly evolving field. So as you'll see by the end of this talk, essentially the paradigm of thyroid cancer treatment is shifting towards doing a lot less intervention for low-risk thyroid cancer, but a lot more variety of options for treatment for high-risk thyroid cancer. So just to briefly go through a little bit of epidemiology, this is data from the SEER cancer database based out of the US. And essentially what you see in this graph is that we've had a very large sudden increase in incidence in thyroid cancer between the 90s up until 2000s. And this is largely due to an increased rate of detection from imaging, incidental findings. And that's important to keep in mind. And then you kind of see it plateaus and maybe starts to decrease a little bit here after 2017, 2015. And that's in large part due to our TIRAD scoring system, which I'll go through, which created a bit more of a discerning approach to when we FNA thyroid nodules, and also the publication of the 2015 American Thyroid Association guidelines on thyroid cancer. And then the other important thing to draw your attention to here is at the bottom, you can see that although the incidence may be rising or fluctuating, the death rate or mortality rate is pretty static through the years and generally quite low. So speaking of our theoretical patient, how would they find thyroid cancer or be diagnosed with it? Usually it's a neck ultrasound done for other indications. The classic one we see is someone getting a neck ultrasound for, let's say, carotid artery stenosis assessment, and then there's an incidental finding of a thyroid nodule. I've had a couple patients who've presented after a dentist found a nodule when they were around their mouth or neck doing dental procedures. So it's often picked up incidentally, also on cross-sectional imaging, CTs, MRIs for other indications. Sometimes it is a palpable or visible nodule seen on exam by the patient themselves or a healthcare provider. One that's been coming up more recently is incidental findings on PET scans. So patients who are getting PET scans for staging of most commonly breast or lung cancer happen to find FDG avid nodules in the neck that then starts the process of investigating that, which otherwise would have never been found. And then very rarely does thyroid cancer present with an enlarging neck mass, usually anaplastic thyroid cancer or very large growing lymph nodes causing airway compromise. So let's say our patient had a thyroid nodule, it was found, and now we see the patient and we want to know, what do we do about this thyroid nodule? Well, we now use the TIRAD scoring system. So what that is, and a lot of you may be familiar with it already, is essentially a radiologic scoring system based on the appearance of the nodule. And there's points allotted for the composition of the nodule, and then that score equates to at what interval you should be monitoring this nodule and when you should FNA the nodule. And I have the table here on the right that equates the scoring of the TIRADs with the risk of malignancy. So you can see a TIRADS 1 nodule has a pretty low risk of malignancy. When you're getting into your TR4, TR5 nodules, it's 9 to 30% risk of malignancy.
Here.
So I should also say that the TIRAD system was initially created in 2009 with some modifications in 2017, and probably around 2017 to 2018 was when it was more universally adopted. So here at St. Joe's and HHS, all our radiologists report thyroid nodules using the TIRAD scoring system, but it is very variable in community centers or community imaging centers with reports we get where they don't necessarily use the TIRAD scoring system, or they interpret it or use it in a different way. And that's why often when we get external referrals for thyroid nodules with the request of a FNA, our interventional radiologist won't biopsy that nodule until they've had a ultrasound report by one of our, excuse me, St. Joe's radiologists with a TIRAD score. And I find that probably about half the time, the TIRAD score is downgraded when our radiologists report it, and often an FNA is avoided. So just some quick important notes about the TIRADs. So the TIRADs is a scoring system, so we have to personalize that for the patient's risk factors. It's not the end all and be all of when we should biopsy nodules. So some things that are going to sway you to biopsy a nodule at a lower threshold than the TIRADS threshold is, for example, a patient who had a history of childhood radiation, or if the nodule is FDG avid, or the location of the nodule. So if it's in the isthmus, then you might want to biopsy it sooner, just because of the increased risk of symptoms there. Or the patient preference. So if they're meeting FNA criteria, but the patient is older with multiple comorbidities and doesn't want invasive interventions, that's also very important to take into account. And then lymph nodes. So the TIRADS is looking at the thyroid nodules, but it's very important to look at the ultrasound report for abnormal lymph nodes. So if there's a thyroid nodule and an abnormal lymph node, you're going to biopsy the lymph node and likely the thyroid nodule at a lower threshold. And that usually indicates a pathologic process, regardless of the TIRAD score. And then the 1 centimeter cutoff. So I'm just going to quickly mention that even when you have TR4, TR5 nodules, which have a high risk of malignancy, we still don't biopsy them if they're under 1 centimeter in size. And the reason for that is even if it is thyroid cancer, the likelihood that it's clinically significant is very low. I have a quick graph here that shows that up to 10% of adults at autopsy are found to have small thyroid cancers less than 1.5 centimeters, and they rarely progress and rarely need treatment. So we should be careful about over-investigating sub-centimeter nodules. And then a quick note about hot versus cold nodules. So the kind of blanket statement is all hot nodules are benign and cold nodules need investigation. And we're seeing more studies that that's not necessarily true. So up to 5 to 10% of hot nodules can have a higher risk of malignancy. And that seems to be especially true in Graves patients. I don't think it's well understood yet, but for whatever reason, patients with Graves' disease with nodules tend to have a higher risk of malignancy. And so my interpretation is that we should really be FNAing nodules purely based on their TIRAD scoring, regardless of if it's a hot nodule or a cold nodule, because there is still an associated risk of malignancy. So back to our theoretical patient, we incidentally found this nodule. Our radiologist reported it as, let's say, a TR4. It's higher than 1 centimeter in size. So we are going to FNA this nodule. It meets criteria for FNA. And let's say we did the FNA, we get our cytology report back. And the cytology report is going to be reported as one of these categories. So this is the Bethesda version 3 cytology reporting system. And I'm going to draw your attention to a couple things on this table. So I think it's pretty straightforward that if it's benign, low risk of malignancy, we're either just going to continue surveillance of the nodule according to TIRADS, or if the patient prefers not to continue, that's also an option. Or Bethesda score comes back as suspicious for malignancy or malignant, so high risk of malignancy, that patient is likely going to see a surgeon at that point. But what if the FNA is non-diagnostic? That doesn't mean zero risk of cancer. So about 0 to 10% risk of malignancy for non-diagnostic FNAs. The previous guidelines used to say that we had to wait 3 months before repeating the FNA because of some theoretical risk of disruption in the cytology from the FNA needle. But the updated guidelines are now going to say that you can repeat that FNA right away. So essentially repeating it is probably the first step for non-diagnostic FNAs. But what about this category 3 and 4 Bethesda, which is your atypia of unknown significance or follicular neoplasm? And that's about a 15 to 20% risk of malignancy is what we quote to patients. So this used to be a huge area of uncertainty in practice because do we repeat the FNA? Do we keep monitoring? Or when patients hear 15 to 20 risk of percent of malignancy, obviously they're anxious about that. And then sometimes we go down the route of a diagnostic lobectomy. So the patient says, just take out that side with the nodule because we don't know if it's malignant or not. And I'd rather not leave it in there. And sometimes that diagnostic lobectomy on final pathology is malignant and sometimes it's not. But luckily, there's been a lot of work in this area. And now there's the option of molecular testing. So molecular testing of thyroid nodules is essentially an RNA-based genetic sequencing of the FNA cytology from these indeterminate nodules. And basically, it's able to test for all the common thyroid cancer genetic mutations and then give us a more definitive answer. Is this malignant? Is this benign? Or if it can't determine that, it will give you a percentage of how likely it is malignant or benign. And that will obviously reduce the rate of incorrect diagnosis, reduce the rate of unnecessary diagnostic lobectomies or surgery, peace of mind for patients, and obviously a lot of advantage. So molecular testing, and sorry, I should mention it has a very high sensitivity, about 90%, a bit of a lower specificity at 68 to 82%, depending on which genetic assay is used. In the US, this is widely available and used. You can see a graph here doing a cost of patient care analysis in the US, and essentially for cost per correct diagnosis for a lobectomy, it's much higher than one of these genetic testings. So is it covered by OHIP in Ontario? No, it's not. Ontario Health did their own sort of cost analysis assessment or a health technology assessment. And essentially, they found, yes, it increases correct diagnosis. Yes, reduces unnecessary surgery, improved quality of life, but increased costs. So if we were to implement molecular testing of thyroid nodules, it would cost Ontario about $6.2 million over the next 5 years. However, that's based on the current pricing. It's kind of under review and fluctuating, so this may change. In Toronto and soon at McMaster, molecular testing will be available, but it will be an out-of-pocket cost for patients for the time being. It's about $600 to $800 out of pocket, but it will be available as an option. So back to our theoretical patient, they had an FNA of their nodule. And let's say it was overall looking like a low-risk nodule. It's about, let's say, 1.5 centimeters. There's no associated lymph nodes. It looks intrathyroidal. And we go back to the patient and we say, well, we now have some options. So we could not do anything about this thyroid cancer. Well, I should say not do anything, but active surveillance of the nodule. So not do surgery. And active surveillance of low-risk thyroid cancer is definitely an evolving field. So we have other cancers, for example, prostate cancer, where we know it's a widely accepted protocol for monitoring low-risk prostate cancer and just active surveillance. And thyroid cancer, I think, is shifting that way now. So what does active surveillance in thyroid cancer mean? So neck ultrasounds every 6 months for nodules that meet low-risk criteria. And there's been an abundance of research in this topic, especially groups out of Korea. Korea has a very high incidence of thyroid cancer and is really a hub of thyroid cancer research, and a lot of research out of Memorial Sloan Kettering in New York. And in their protocols and studies, active surveillance and surgery both had similar outcomes: low rates of growth, mortality, and distant mets, and a very low rate of subsequent surgery for patients who elected to have active surveillance. And the times that surgery was done was not because of nodule growth, but rather because of patient preference. So overall, patients do very well. And then the other option is, okay, well, we're going to operate. Maybe it doesn't meet active surveillance criteria, but what about less surgery versus a total thyroidectomy? So a lobectomy versus a total. And the new American Thyroid Association guidelines, which are very overdue, but supposedly coming out next year, are going to have, a lot of recommendations about when we can do less versus more surgery. And one question people might have is, well, you're going to go in there anyway, you're going to take some thyroid out, just take the whole thing out versus a lobe. What's the difference? So there is a difference for the patient, and that's less recovery time with lobectomies, less risk of needing a lifelong synthroid replacement, which obviously you would with a total, less risk of recurrent laryngeal nerve injury or vocal cord paralysis, and complications in general. So it does matter. When we can do less, we should do less. Now, I touched on active surveillance already in all the research out there, but I just want to make a quick mention about the active surveillance Canadian thyroid cancer study. So this is a study that's based out of Princess Margaret and UHN in Toronto. It's a multi-center study. They're, I think, just about finished recruiting patients who meet very specific criteria for the option of active surveillance of their thyroid cancer. Our ENT group at St. Joe's was actually part of this study in one of the centers. So it's going to start the phase 2 part of the trial soon. And so this will be interesting when it is finished, about developing our own local protocol for active surveillance here. So back to our theoretical patient, let's say they had their FNA, it's thyroid cancer, and it doesn't meet criteria for active surveillance. Let's say it's a little bit larger, like a 3-centimeter thyroid cancer. Maybe there's a couple central lymph nodes involved on imaging, and they need to have surgery. So they see ENT, they have their surgery, a total thyroidectomy, and some degree of neck dissection or lymph node dissection, depending on imaging. And now surgery is done with them. They've done their part, and they refer them to me, and they say, does this patient need radioactive iodine? Or do they need any further treatments, or are you just going to watch them for recurrence? So in the past, everybody who had thyroid cancer got a total thyroidectomy, high-dose radioactive iodine, TSH suppression, and that was kind of, everyone got that. But now we have a lot of data and tools for assessing the risk of recurrence and being able to do more or less depending on that. So after surgery, when they get sent to us, what we do is a post-surgical risk stratification. And this is from the American Thyroid Association. Based on their pathology report, which is really the cornerstone of risk stratification post-op, we then decide, are they in a low risk for recurrence category, an intermediate risk for recurrence category, or a high risk for recurrence category? Based on that, we then decide if they need radioactive iodine. And I put this summary up, but essentially it's kind of the same as you would expect for any cancer. If it's small and there's no local or distant mets and it doesn't have high risk features, it's low risk. Once you have aggressive histological subtypes, lateral lymph nodes involved that are further away, large lymph nodes, extranodal extension, extrathyroidal extension, obviously you're going towards higher risk at that point. So if they're in a low risk category, then they're not going to benefit from radioactive iodine, and we just watch those patients. If they're in intermediate or high risk category, then there is evidence to say that yes, radioactive iodine does significantly reduce the risk of recurrence. So what is radioactive iodine therapy? Some of you may be familiar with RAI in the context of Graves' disease or toxic nodules. And it's the same idea in thyroid cancer with a few differences, but really the main difference is that it's much higher doses. So if you're using millicuries as your units, you're using somewhere between, let's say, 5 to 15 millicuries for Graves or toxic nodules. In thyroid cancer, you're usually using minimum of 30 and up to 200 millicuries. And the way it works essentially is endocrinologist would order the RAI, nuclear medicine administers it, and it comes in either a capsule or a liquid, which it has inside it iodine that's been treated with radioactivity. They swallow that and it gets absorbed. So thyroid tissue or thyroid cells express sodium iodide symporters on their surface and have a very high affinity for taking up iodine. So anything thyroid left in the body will absorb that iodine, and the radioactivity that it's been treated with will destroy that tissue slowly over a 3 to 6 month period after administration. And then a week after the treatment is given, they get a radioactive whole body scan. And that will light up or show us where there was any uptake of iodine. And we can see where there's any active tissue. So any uptake on that scan is either benign remnant tissue. So the surgeon takes out the thyroid, but maybe there's a little piece here or there that's still left, or anything that uptakes it is residual disease, sometimes very small metastatic lymph nodes, for example, or distant mets. Maybe we didn't know that they had lung mets that weren't on the CT, or they had indeterminate lung nodules on a CT, but now those lung nodules on the whole body scan are taking up iodine. So that confirms that those nodules are thyroid cancer. All that to say that the special thing about radioactive iodine in thyroid cancer is that it's a theragnostic modality, which means it's both therapeutic and diagnostic, because it can treat residual disease and diagnose where that disease is based on the uptake scan. Of course, there is some caveats to use of radioactive iodine. So number one, the disease will only uptake the iodine if it's differentiated enough to express the sodium iodide symporters. So when you have poorly differentiated thyroid cancer or anaplastic thyroid cancer or medullary thyroid cancer, those don't express those transporters, so RAI is not going to work. Or you have disease that initially took up radioactive iodine, but on a recurrence is now resistant to radioactive iodine. So that's a possibility. And this is kind of what a post-therapy whole body scan looks like. So you can see there's some physiologic uptake in the bowels and the salivary glands, a little bit in the bladder. And that's because those mucosal glands do express some sodium iodide symporter. So that's just considered physiologic uptake. But you can see here that there's some very dark spots in the neck that are taking up iodine. And that's probably a little bit in the central neck, maybe some lymph nodes, maybe some residual disease in the thyroid bed, and some lymph nodes. And then this radioactive iodine whole body scan was repeated a year later, and you can see that now there's no uptake in the neck. So that iodine treatment destroyed that tissue that initially took up the iodine and now is gone. And this would be considered an excellent response to therapy. which brings me to my next point, response to therapy. So back to our theoretical patient. They've had their thyroid cancer surgery. We've done a post-operative risk stratification and determined that they're at least intermediate risk. They should get some radioactive iodine. They've gotten that. And now they come back for follow-up and they say, okay, well, what next? Did I respond to the treatment good? Do I need other treatments? And what should my TSH be? So how do we decide how well they've responded to therapy? Again, this response to therapy stratification is from the American Thyroid Association guidelines. And based on three things, we decide how well they've responded. So it's their radiologic response, their biochemical response, and their clinical response. So radiologic is pretty self-explanatory. They have a NIC ultrasound, and hopefully there's nothing significant on the ultrasound. Biochemical is their thyroglobulin. So thyroglobulin is a protein that's secreted by thyroid follicular cells, and it's an excellent tumor marker for thyroid cancer because essentially nothing else in the body produces thyroglobulin. So as you would imagine, if you've taken your thyroid out and you think you've taken out all the cancer, then your thyroglobulin should be undetectable or zero, and that's the ideal scenario. If you have low but detectable TG that is stable over time, that's reassuring. If it's undetectable, obviously that's great. But if you have a thyroglobulin that's rising exponentially over time, then there's something growing somewhere because nothing else produces TG. And so that's how we determine biochemical response. And an important thing about TG is, number one, only differentiated thyroid cancer cells will produce thyroglobulin. So if you have poorly differentiated disease, it may not make your TG tumor marker. And the other important thing about TG is TG antibodies. So anytime we measure thyroglobulin as a tumor marker for thyroid cancer, we have to measure thyroglobulin antibodies at the same time. And about 20 to 30% of the population has TG antibodies circulating in the blood. Doesn't necessarily mean anything. But if you do have TG antibodies, then that interferes with the measurement assay of thyroglobulin in the lab. So you're going to get falsely low TG levels. So you can't use TG reliably in a patient who has TG antibodies. You can use the antibody levels as a surrogate for TG to measure over time. So if your TG antibodies are increasing over time, then probably something is growing somewhere. But for those patients, we do have to maybe do more imaging or have a lower threshold to investigate NUC ultrasound findings. And then the third thing was the clinical response to therapy. And that just essentially means that you're not able to feel any gross disease on exam. Based on those three things, we then decide, are they displaying an excellent response to therapy, an indeterminate response, a biochemical incomplete, or a structural incomplete response? And then that will determine our TSH goal. So obviously, after they've had their thyroid out, they have to be on Synthroid. But what should their TSH be? And that brings me to TSH suppression. So why do we do it and what is it? So the initial data used to show that keeping your TSH low reduces the risk of cancer growing. So TSH, as the name would suggest, is thyroid stimulating hormone, so it stimulates thyroid tissue. The exact mechanism of that is not very clear, especially in thyroid cancer. But everybody used to get a TSH suppressed less than 0.1 after thyroidectomy for thyroid cancer, regardless of what their risk stratification was. And that was based on pretty poor data initially. And the 2015 ATA guidelines, which we use at the moment, have this table and these suggestions. So based on the response to therapy, they suggest that you should have no TSH suppression if you have an excellent response to therapy. And then mild TSH suppression up to 0.5 in the middle categories, and then complete suppression in higher risk patients. And they do have a little bit of a continuum here for risk. So let's say it's an older patient with a history of AFib and osteoporosis, maybe you can relax the TSH target a little bit. However, there's been a lot of recent data that is now showing us that, you know what, does TSH suppression actually work or make a difference? And we're starting to see that no, not as much as we thought. So there's a systematic review here. This is the most recent publication on this topic. But essentially, the TSH targets over time are loosening. And I think that the new updated ATA guidelines coming out next year will move away from complete TSH suppression. So what we're seeing now is that keeping TSH at subnormal, so that's somewhere between 0.5 to 1, is equally effective as complete TSH suppression for reducing recurrence, or at least no difference. And way less side effects. So we know that we're increasing the risk of AFib, osteoporosis, especially in postmenopausal women, and other cardiac complications when we keep TSH suppressed. So that's where the evidence is shifting here. And that's important because a lot of the time patients will come to us with a completely suppressed TSH for many years with anxiety and osteoporosis and all these things. And it's hard for them to accept when we say, actually, we don't need to do this anymore because that's what it's been done for so many years. And also, as other healthcare providers who might be seeing these thyroid cancer patients, sometimes patients get their Synthroid dose adjusted because someone sees their TSH is low. So we do tell patients to let people know that your TSH is supposed to be low, and an endocrinologist hopefully is adjusting it after thyroid cancer because we do want to keep it in a specific range. So back to our theoretical patient, they've had their surgery, their radioactive iodine, we've determined their response to therapy, and we've determined what their TSH should be, and we're happy with where it is now. So what do we do with them long-term now? So they undergo surveillance for recurrence, and that entails neck ultrasounds every 6 months, tumor marker monitoring, so their TG and TG antibodies, and a TSH every 6 months. And the highest risk of a recurrence is the first 5 years after surgery. So that's when we're monitoring the closest. But over time, especially if they're displaying excellent response to therapy, that interval does increase. So 6 months to every 12 months to every 2 years at some point, but then for how long? And that's a question that nobody knows the answer to. At the moment, there's a variability in what practitioners are doing. So some people follow for 10 years, some people follow for 15. High risk patients probably will follow forever. And the new guidelines hopefully should have some update on when we can discharge patients from surveillance back to their family doctors with specific instructions, and when we can stop checking. And then let's say you're doing your surveillance and something comes up. So their TG is rising, or there's something suspicious on the ultrasound, or they say, hey, there's a lymph node here that I recently felt and it's growing. So what would we do at that point? Well, that would warrant further investigation. So cross-sectional imaging, FNAs, PET scan, depending on the scenario, and then treatment options for that recurrence. So let's say that did happen to our theoretical patient. They had something came up on their neck ultrasound and it correlates with a TG that's beginning to rise. We FNA that lymph node and it's positive for PTC. And so they've had a recurrence now. What do we do about it? Well, that depends on a lot of things. If it's, let's say, a young patient who has a lymph node recurrence, the lymph node is relatively small and not in a location that's worrisome, there is the option to just watch it. We know that thyroid cancer grows very slowly, and we know that young patients have a higher affinity for lymph node recurrences. So we don't want to keep cutting open their neck and plucking out every lymph node that comes back. So often we're waiting until they meet the threshold for surgery, or it may never grow and we may never have to go in surgically. So watching is an option for a recurrence. Or revision surgery. So if there's a lot of lymph nodes that they're growing rapidly or there's a concern, then they would go in for a lymph node dissection or a compartmental neck dissection to clear out lymph nodes from that area where we think it's recurred. Sometimes we give another dose of radioactive iodine. So especially if the cancer was RAI avid and previously responded to radioactive iodine, sometimes patients get repeat doses. External beam radiation or radiation for locally symptomatic disease. So let's say it's a bone met with a pathological fracture or a spine met that we're trying to avoid spinal compression for, then radiation is a possibility. And then systemic therapy. So sometimes we're doing multiple treatments from this list in conjunction, but at some point patients may need systemic therapy depending on the burden of disease and the location of disease recurrence. So a quick note about systemic therapy. Conventional chemotherapy is not used in thyroid cancer, so we have systemic therapy, usually tyrosine kinase inhibitors that are oral treatments. And the good thing about thyroid cancer is that most of them have identifiable somatic genetic abnormalities that we can target. So prior, the only option was the bottom of this table, which was not a targeted therapy. It was tyrosine kinase inhibitors, mainly lenvatinib, and everybody who needed systemic therapy got lenvatinib. But now we have therapies targeted to specific gene alterations. So this is FDA approved drugs, but some of these are approved in Canada and we do use them. And depending on the genetic makeup of the tumor, which we can test in a gene sequencing, we can target the drug to the gene alteration, whether it's a BRAF mutation, a RET fusion, NTRK fusions, etc. And this has especially been successful in anaplastic thyroid cancer. So we used to think of anaplastic thyroid cancer as a cancer that people die of usually within 6 months of diagnosis. But where these targeted therapies are going and the clinical trials now showing that survivals can be up to 5-10 years with anaplastic thyroid cancer. So it's definitely an evolving field. And I wanted to make a quick note about something called redifferentiation therapy, which is very interesting. But I mentioned earlier that radioactive iodine is only used in differentiated thyroid cancer that can take up the iodine. But now we have new targeted therapy drugs that can essentially upregulate the expression of sodium iodide receptors on cell surfaces and redifferentiate the cancer to be able to take up radioactive iodine. So you can see here a iodine whole body scan where not much is lighting up other than a bit in the neck. After redifferentiation therapy with selumetinib, you can see that all these lung nodules that were not taking up iodine before now are RAI avid on the scan. And then these are just the SPECT CTs essentially showing the same thing. But this has a huge implication for patients because radioactive iodine, when it works well. It can buy us a lot of time with progression of disease, and relative to other cancer treatments has a low morbidity and side effects. So if there's a therapy that can let us use it at times where it was resistant, it would be a very interesting direction for thyroid cancer treatment. So to wrap up a few points, overall, the pendulum is shifting to less for low risk, avoid overtreatment, more options for high risk cancer, and evolving therapies. We, instead of using a a blanket sort of treatment for all patients. Everyone gets thyroidectomy, RAI, and TSH suppression. We can now use the risk stratification and response to therapy to guide decisions so that we're not over treating these patients who often do very well with thyroid cancer. And targeted personalized options with genetic alterations. And a final important point I want to make is that you heard me talk a lot about the risk of recurrence in thyroid cancer, but you didn't hear me talk a lot about mortality or a 5-year survival, for example, like other cancers. And the important thing here is because thyroid cancer has such a good prognosis, overall, we're not necessarily worried about these patients dying of thyroid cancer, although that does happen. It's more so recurrence-free survival as the main indicator that we care about in thyroid cancer, because although they're going to live a long life after their diagnosis of thyroid cancer, how many times will it recur and what treatments will they need? And that really dictates the quality of life and associated morbidity with thyroid cancer rather than the mortality. And that's where the focus is. So I think that's everything I had. Just wanted to wrap up and hand it over back to Rima or whoever is there.
Thank you so much, Dr. Abu-Hijleh. The wonderful overview of a topic that you bring so much expertise with you to your role, and we're also grateful to learn from you and that our patients in our community are able to benefit from your expertise. So thank you. We have some time for questions, so I will invite everyone among our attendees here to feel free to raise a hand if you'd like to ask a question, unmute, or enter any questions you may have into the chat or Q&A function. And I'll get us started off, Tala. So help me to understand as a referring physician. So actually, as a hematologist, we do a lot of like lymph node exams. So I have picked up several thyroid nodules, and I'm often not exactly sure how to navigate the system on behalf of the patient, like what the entry point is. So can you help us to understand how you collaborate with the head and neck surgeons, and what the ideal flow of these referrals is? Should they be coming first to a general endocrinology clinic and then they make their way to you? Should we refer to you? If they start in the head and neck surgeon office, how does that? So I guess two questions there. Where would be the first point of contact for referring physicians, whether that's primary care physicians or, as you highlighted, physicians of all stripes who may be examining or reviewing radiologic investigations? And then help us to understand how your collaboration works with the surgeons.
Yeah, so I think I kind of touched on this earlier, that there's a lot of overlap between who does what in thyroid nodules and thyroid cancer, and that's especially true between endocrinology and the head and neck surgeons. So I think when a thyroid nodule is picked up, it either gets referred to an endocrinologist or a surgeon. And when that happens and where they should go is very variable, and it's very much a choice on the referring physician. So some of them will end up with surgeons and some of them will end up with us. So if they end up in our clinic, we're gonna follow the TIRADS classification essentially and decide how often we're ultrasounding the nodules and if they need FNA. If we do FNA the nodule and it's suspicious, then we send it to surgery. If we FNA the nodule and it's non-diagnostic and the patient is anxious and the nodule is causing symptoms or compressive issues, we're sending it to the surgeon. Otherwise, we follow them over time. And then if the surgeons are the primary contact, they will do the exact same thing. I guess the advantage is that they can do the ultrasound and biopsy themselves in clinic, so it kind of saves a step for the patient. But then surgeons often, their clinics are getting backlogged with all these nodules that they're just following for years and years that they're not doing anything about. So I don't have a good answer about who it should go to first or where the best place is. There is a lot of, so to speak from a thyroid cancer perspective, not from a nodule perspective, the surgeons are often involved initially, and then an endocrinologist will kind of monitor long term after the surgery. But there is a lot of overlap and redundancy for patients, especially I find patients who are coming out of catchment areas and driving long times to see me for their thyroid cancer follow-up, and then the surgeon like 2 weeks later. Sometimes they get 2 ultrasounds or redundant blood work. So I am talking to the head and neck surgeons about a multidisciplinary clinic, which hopefully that's where this is going, to kind of streamline the process. So I don't know if that answered your question at all, but it's a work in progress, I think, because there's no unified process.
That absolutely answers my question, and seeing that you're taking on a role as a champion for streamlining care is really exciting. And we can have some follow-up conversations. Just make sure myself and Dr. Shah are able to best support you in those efforts. I think that's very patient-centered, and as a regional site, I think it's the right thing to do. So thank you for that. Speaking of which, I'll hand things over to Dr. Shah in case she has, it looks like she had a question or comment as well.
Sorry, I just wanted to tag along to an answer to your question. Just as Tala mentioned, the logistics of having an ultrasound done at an outside institution, if that meets indications for FNA and comes to endocrinology, our first step will be repeating the ultrasound locally. And so one thing for you as hematologists or other providers to keep in mind, it's always helpful to have, if you can do a local ultrasound at one of the St. Joe's or HHS facilities, then that as a starting point, that may help streamline things going forward as well in terms of avoiding the double step of a repeat ultrasound and then biopsy. And it may be that they don't even need the biopsy based on the ultrasound done here.
Yeah, thank you. Yeah, absolutely.
Excellent. That's so helpful. Yeah. Rima, go ahead.
Oh, I was just going to say, I think I don't see any other questions. So maybe, Tala, I'll just get you to comment. A question we often see from internists and family doctors is around Ozempic use, which is becoming a lot more common in our diabetes patients in particular. And a lot of the time, people will ask us about, a lot of patients obviously have thyroid nodules, and the question comes to us about what to do. Do they stop the Ozempic? Do they not? So I'm just wondering if you could, if you wanted to comment on that.
Yeah, I think that so the whole link between Ozempic and thyroid cancer was found in rat studies, not human studies, and it was, I should say, not well replicated, but essentially it's only medullary thyroid cancer, not your general run-of-the-mill thyroid cancers. And medullary thyroid cancer in and of itself is extremely rare. And so I would only really be concerned about patients who had a history of medullary thyroid cancer in a first-degree relative, or a personal history of, let's say, Men's syndrome, or known genetic mutations in the RET gene. And otherwise, if they have a thyroid nodule, even a history of thyroid cancer, I'm still pretty comfortable with them being on Ozempic for other indications. There was some data at the last ATA about potentially increased risk of papillary thyroid cancer with Ozempic. So it's definitely an area that's being researched, but I don't think there's enough data right now to to say that it doesn't warrant the benefits of Ozempic, especially for our diabetes patients. So I think that it's a benefit risk discussion, but overall, from a provider perspective, I would be comfortable with the very low risk.
Excellent. Thank you both so much for that question and response. And just as we wind down our time together here today, and I see there don't appear to be any other questions from our audience, I'd just like to thank you both again today, Dr. Shaw in your head of service role for joining and co-hosting and for the leadership that you provide, and to Dr. Abu-Hijleh again for a phenomenal presentation and a really excellent discussion. And thank you again for all that you do for our patients. And as we wrap things up, I know we're a week late on Doctors' Day, but we'll make it Doctors' Month and celebrate all of you and the work that you do. And thank you to Kathy Vermeltfort for organizing these medical grand rounds and for keeping everything running smoothly. I wish you all a wonderful rest of your day and week ahead. The next rounds will be same time next week with HHS as the host site. And then the following week, May 22nd, we'll be back with St. Joe's as host site, and we'll be having a special endocrinology again, visiting speaker as part of the endocrinology education day that's happening. So thanks to everyone and have a wonderful day. Take care.
Thank you.